everybody. Welcome to OsteoBytes, and thanks for joining us today. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBytes, we are joined by Dr. Chris Thompson from Ethos Veterinary Health to discuss the minimally invasive metastasectomy in canines, also known as the MIMIC clinical trial, which I much prefer because it has far fewer syllables, which will assess the feasibility and tolerability of VATS for lung metastasis in canine osteosarcoma patients. Thanks so much, Dr. Thompson, for joining us on OsteoBytes today. We are thrilled to have you. And thank you also to our panelist, Max, for joining us today. Please feel free to submit questions throughout the presentation using the Q&A in Zoom, and we will share those with Dr. Thompson after his presentation. A little bit more about our guest today. Dr. Chris Thompson earned his veterinary doctorate from the University of Minnesota, and following a rotating internship at the University of Wisconsin-Madison, he returned to the University of Minnesota for a residency in small animal surgery. Following residency, he completed a fellowship in surgical oncology at Colorado State University. Dr. Thompson has been on the executive board of the Veterinary Endoscopy Society for 5 years and is an active member of the Veterinary Society for Surgical Oncology and the Veterinary Interventional Radiology and Interventional Endoscopy Society. Through minimally invasive or keyhole surgery, Dr. Thompson is driven to minimize the pain and complications related to surgery while maximizing patient outcomes. Similarly, with the use of interventional radiology, Dr. Thompson can treat various forms of unresectable or metastatic tumors through ablations or chemoembolization. Dr. Thompson is also an active participant in clinical research with Ethos Discovery, with projects focusing on minimally invasive treatments for osteosarcoma, liver diseases, urogenital cancer, and several others. Thanks so much for joining us today, Dr. Thompson. We are very much looking forward to your talk. Just a few announcements before we get started. Whenever we have an episode featuring work on canine osteosarcoma, I like to highlight our Canine Clinical Trials resource on our website. It provides information and resources on participating in clinical trials, as well as a directory of veterinary oncology programs and open canine osteosarcoma trials, including the study Dr. Thompson will be discussing today. So I'll put a link in the chat to that. We also have a comparative oncology playlist on our MIB Agents YouTube channel. So if you're interested in this episode, you'll likely find content that you're interested in our channel. So I'll also put that in the chat. And then lastly, I wanted to plug a cool event that is happening next week, February 11th. Comparative Oncology is being featured in a PBS documentary series called Shelter Me, and the episode is called The Cancer Pioneers, and there is an in-person premiere in Bethesda, Maryland, next week on Feb 11th at 7 p.m. The film is about groundbreaking clinical trials for dogs with cancer and how these treatments are being applied to people with cancer, and the film features some of the leading scientists at the National Cancer Institute, the University of Pennsylvania, the University of Illinois, and the University of Wisconsin. And there will be a panel discussion and Q&A following the film. So I'll put more info in the chat about details and how to RSVP. Max, could you please introduce yourself?
Hi, my name is Max. I'm an osteo warrior and was diagnosed with osteosarcoma in 2015 when I was 10 years old. Since then, I've been almost 8 years NED and am currently involved with MIB as an ambassador agent and on the junior advisory board. I'll hand it over to Dr. Thompson.
Awesome. Thanks so much. Is it good just to get started now, Christine?
Yeah, let's go ahead and we'll get your slides up. And again, really looking forward to this. You know, as I was kind of thinking about your presentation, I remember back, we have a AYA cancer podcast called Osteo, and they did an episode a few months back, but it was kind of about their different surgery experiences. And they actually ended up kind of talking about like pros and cons of different procedures they've had. And I remember obviously the thoracoscopy came up as, way better in terms of, pain and recovery time. And even just from personal experience, with my son, I just remember, gosh, it was so great. And also interesting, there's a clinical trial happening right now in humans kind of both. Yeah. Both the thoracoscopy versus open. So
yeah, I appreciate that.
Yeah.
Cool. So I'll kind of take over now. And I'm glad you mentioned that. I was actually going to start with exactly that, and that we are very excited about this trial. It's been ongoing for about a little over 3 years now. And it's very much, like you said, is because of the benefit that it can have for patients, both for just performing a metastasectomy, but then really the advantages for the patients from a less invasive surgical option, and is exciting because our research into this area is actually mimicking or copying what's seen in humans, where they are doing a almost identical clinical trial for humans with metastatic osteosarcoma, and comparing thoracoscopic procedures compared to an open conventional thoracotomy. So really exciting that, again, there's such a close mirroring in vet med and human medicine on this topic. So really excited to be here. It's a privilege to be here with you and Max. Really excited to talk about where we're at with this clinical trial and where we're hoping to have it headed in the future. So today we're going to be talking about our minimally invasive metastasectomy in canines. We do call it MIMIC, as Christina said, just to minimize the number of times we have to say metastasectomy. This is a project that I've been very passionately putting on here in San Diego for, again, about 3 years, with the goal of trying to provide a minimally invasive surgery for dogs with metastatic osteosarcoma and other cancers. This financial disclosure, so I'm an employee of Ethos Veterinary Health. I'm going to talk about that in just a second. This obviously is through Ethos Discovery, which is a nonprofit research incubator for a variety of things, which includes cancers like osteosarcoma and hemangiosarcoma. The majority of the funding for this project has been through Ethos Discovery, meaning that this has all been done thanks to in-kind donations to the nonprofit Ethos Discovery. And again, this is also subsidized through Morris Animal Foundation, which we got a fund or a grant recently for getting more patients treated. So what is this? Why am I here and talking about this? So I'm a veterinary surgical oncologist. I'm practicing in San Diego. I've always had a passion for clinical research and have that kind of unending curiosity for why can we not do something better, or kind of thinking about how we can improve outcomes for our patients. Actually, I always imagined myself going into one of the classic academic institutions that you had mentioned to actually do a lot of this clinical research, but very fortunate to have been introduced to Dr. John Khanna early on in my career to learn about the fact that we can actually do very advanced clinical research within private practice in vet med. And again, that's all through Ethos Veterinary Health and specifically through Ethos Discovery. So Ethos Discovery, like I said, is our nonprofit research incubator. We focus on a variety of things within several different clinician scientists that have programs in Ethos Discovery. Mine, again, is focused on innovations in surgery with an emphasis on osteosarcoma, as well as a couple of other cancers and minimally invasive treatments. We do have a pretty wide portfolio of clinical trials available. They're scattered throughout all of our clinics within Ethos Veterinary Health that are focused on, again, various cancers, things like neurosurgery and neurodiseases in dogs, as well as a variety of internal medicine features as well. And the one that I'm excited to be talking about today, and kind of what we're here to discuss, is the MIMIC clinical trial. So the basis, or kind of why we are doing this in the first place, is truly summarized in this slide, and that we know that lung metastasis is a common cause of mortality in dogs and people for osteosarcoma, and has been the really challenging thing for us to be able to fight and treat for the longest time. Meaning we've made improvements in local control, as well as slowing down or giving us extra time from the time of local treatment to the development of metastasis. But once a patient develops metastasis, it can be a very difficult thing to treat, and has been very non-responsive to a lot of the drugs or treatments that we've attempted so far. In people, we know that there's a very robust amount of data that if you can undergo a metastasectomy, once pulmonary metastasis has developed, you can have a very good survival advantage for those patients and for those cases. But historically, this was essentially not performed in dogs. And so we really took a step back and said, if we already know that this has a survival advantage for our patients, why is it not being performed? And similar to what Christina was mentioning, a lot of that really comes down to the fear associated with more open conventional techniques. Getting into some of the data. So so again, this is really from the human side of things. We know that for patients that develop lung metastasis, when it is amenable to surgery, surgery almost undeniably provides a survival advantage when it's possible. One of the landmark articles that has looked at this was back in 1997, where they looked at the lung metastasis registry, and again found that if surgery was possible and surgery was undertaken, those patients really had a very substantial survival advantage. If you compare the 5-year survival for those that did or did not undergo surgery, the 5-year survival for those that underwent surgery was 36% compared to only 13% for those that did not. And of all of the factors they looked at, which included the size of the nodules, the location of the nodules, the number of nodules, the most, or I guess one of the patients with the greatest odds of surviving were those that had a complete surgical remission compared to those that did not. This was followed up within that same lung metastasis registry, but specifically for osteosarcoma about a decade later, where they looked at 1,700 patients with osteosarcoma that underwent surgery or did not undergo surgery. And again, patients that had their osteosarcoma metastasis excised had a 40% 5-year survival versus 0% when it was not resected. So it really does emphasize what an important place surgery has for lung metastasis within osteosarcoma. We have a little bit of data in dogs, meaning that where I did my fellowship at Colorado State, they did a similar retrospective evaluation of cases. And for dogs that had lung metastasis from osteosarcoma, if you look at 194 patients, those that underwent metastasectomy had a survival advantage of 230 days compared to those that did not have surgery of only 49 days. And so again, really emphasizes that there is a substantial benefit if this can be performed. Obviously, when you're looking at this retrospective data, there's always a concern about bias, meaning are we selecting for a less aggressive disease because those are the ones that can undergo surgery? And so they tried to look at specifically just qualifying dogs, meaning dogs that had fewer than 3 nodules and a 275-day disease-free interval from the time of local control to development of lung metastasis. So looking at a more uniform data set. And again, even for those cases, if surgery was performed, there was a very substantial survival advantage compared to those in which surgery was not performed. And so we do have data in dogs to suggest that we should be doing this. But again, the question is, why are we not doing that? So that's really where a MIMIC clinical trial comes into play. And we are trying to emphasize and really bring forward this notion that, number one, this can be performed in dogs. Number two, not only can it be performed in dogs, but it's safe to do so for the majority of our cases. And then number three, if we do it in a minimally invasive manner, these patients can do very well and recover very quickly from surgery. And so the question that we are bringing forward with this MIMIC clinical trial is using video-assisted thoracoscopic surgery. So again, a minimally invasive keyhole surgery. Will our dog patients be able to be discharged in fewer than 40 hours after surgery? The reason we selected 40 hours is because we looked back at our data for dogs that underwent a conventional thoracotomy and found that on average, they were discharged around 40 hours after surgery. And so we wanted to know, could we beat that if we're doing this in a less invasive way? So the way it's set up is it's a prospective funded trial for initially 36 dogs to undergo a thoracoscopic metastasectomy, meaning we set up as a Simon's 2-stage design, meaning if we had success in the first 18 cases, we're going to then subsequently enroll the next 18 cases for a total of 36. And the goal is to assess the therapeutic benefit of surgery for these dogs that have developed metastasis from osteosarcoma, and not only validate that surgery is beneficial and is safe to do, but also to pave way for an accelerated study of lung metastasis, meaning that one of the big things for our ability to treat lung metastasis is we need to get a better understanding of the biology, meaning why is it happening? And so this really provides an ability to do so because it's done in such a prospective manner. So what does this mean and what are we doing? So these patients are coming to now one of 3 hospitals. It initially was just at my practice here in San Diego, but we do have 2 other clinics that are now enrolling cases. These dogs are undergoing advanced thoracic CT scan prior to surgery to determine the location and the number of the nodules. We're doing a variety of both blood-based and tissue sampling for these patients, and then they undergo the thoracoscopic resection. It's near-infrared guided, and I'm going to talk about that in a second. And then after surgery, we're doing regular and routine follow-up, meaning we're assessing how these patients do, as well as the kind of survival advantage that we are getting from surgery. Long-term, we are hoping to not only have this as a surgery intervention only, but we are hoping to integrate and start to add in some adjuvant chemotherapies after metastasectomy. And so that's what I'm going to be talking about at the future of our clinical trial after we get through this initial 36 cases, with the goal of, again, looking at pharmacokinetics, pharmacodynamics of these various drugs that are in the pipeline or promising for humans that we can also test out and provide a therapeutic advantage for our dog patients. Where are we doing this? Again, right now we have 3 hospitals that are open and enrolling. The first, again, 2.5 years, all of this was done at my practice here in San Diego. We, over the last 6 months, opened up a practice in Texas. And then just within the last couple of weeks, we finally got approval to start this at Ontario Veterinary College in Guelph. And so 3 right now, we're hoping to open up at least 2 more clinics within the next 12 months within the United States, again, targeting the Pacific Northwest as well as down in the Florida region to really get a good geographic coverage of where we can provide this. What are the patients that we're doing this on? So inclusion. So initially for the first 18 cases, we actually did all comers, meaning any dog that had a pulmonary metastasis from a variety of different tumor types, meaning not just osteosarcoma for the first 18 cases. Since then, for the last several cases, we've been doing only osteosarcoma. They have to be greater than 5 kilograms just for the feasibility of some of the testing and for the actual thoracoscopic procedure. They have to have their local tumor that was either already controlled or able to be controlled at the time of the metastasectomy with either surgery or radiation. And then these are presumed radiographic pulmonary metastasis, meaning that we do not require pre-surgical cytologic or pathologic diagnosis. They're all presumed metastasis. Exclusion. So one of the big things for thoracoscopy in dogs is that we generally want to exclude patients that have a single nodule that's greater than 5 centimeters. We have hedged on this slightly, meaning we have resected nodules that are as great as 6 to 7 centimeters in size, depending on the patient's size. And then the big thing is that we are not excluding patients based off of the number of nodules or the location of nodules. It's really just if there is less than 60% of lung volume that needs to be resected, meaning that if we have to remove more than 60%, those patients are excluded. This is based off of data that we know that it is safe to surgically remove up to 60% of the lung volume in a dog, and it does not affect their overall recovery. So again, the number of nodules is not excluded. We've done as high as 10 or 11. It's really just the volume of lung that has to be resected. There are other kind of classic exclusions, so things like a high ASA or low performance for these patients if they have extra thoracic metastasis, underlying lung disease, and some other various factors. What are we doing? So the intervention, again, we start with a contrast CT scan to determine location number of the nodules, and then we undergo a thoracoscopic metastasectomy, so a VATS metastasectomy where we're surgically removing these nodules. One of the really exciting ways that this is now able to be performed is because we are using near-infrared intraoperative mapping. And I'm going to talk about that in a couple of slides in just a minute, meaning that we have an ability to actually identify and localize some of these smaller lesions within the lung tissue, which was historically not possible. A lot of these patients are required 1 lung ventilation, meaning that we are anesthetizing and breathing for them on one hemithorax while we are doing surgery on the opposite. And then we're performing complete or partial lung lobectomies depending on the location of the tumor. So this is just a video of kind of a thoracoscopic explorer. So this is using near infrared fluorescence. So I'm going to play the video one more time, but again, this is using a thoracoscope. We are within the chest cavity, and you can see on the video here, this nodule is a tiny 2 millimeter nodule that is on the the axial surface of one of the cranial lung lobes. And if you just look at this image here, it's actually very difficult to identify the metastatic nodule. And that's because of the size and the fact that it is not on the pleural surface. And so if we were just to do a thoracoscopic explore without the near-infrared, it's actually very difficult to identify these nodules. So I'm going to play it again just to emphasize why this newer technology is making an advantage. If I turn on near-infrared, that nodule is very bright. It's highlighted from the actual near-infrared fluorescence. And so this is really one of the amazing things that's allowing us to do this procedure in dogs and in people. This is an example of the one lung ventilation. And so when we are doing the procedure, again, the image on the left is a view from actually during thoracoscopy, meaning that this is a view, you can see the heart beating, you can see the lungs inflating as the patients are getting various breaths. And then the image on the right is of what's called an endobronchial blocker, meaning that we are putting a little balloon on the inside of, in this patient, the right lungs, so that during surgery, that side of the lungs is actually going to be passively deflated, meaning they're not going to be air-filled while we are breathing through the left side. And so this is just kind of a simultaneous view of us doing bronchoscopy to place the balloon to allow the deflation of that side of the lungs, while again, we're going to be looking at things through the scope. And then this is just another video of us actually performing the metastasectomy, or the nodule removal on that first case that we showed the fluorescence on. So again, because the nodule is actually so peripheral within the lungs, you can see that we're just doing a small little partial lobectomy of likely less than 5% of the total lung volume on this lung. So again, just getting in there with what's called a ligament. So it's a self-ligating loop that allows me to ligate that section of the lungs, so we actually can preserve the vast majority of the rest of the lung field. That was played at 2 times speed, meaning sped up compared to normal. And then again, just a good demonstration of where near-infrared can provide a substantial benefit for me as a surgeon. So again, what near-infrared is we give an injection of a contrast agent or a dye. Specifically in this case, it's called indocyanine green. That IV contrast is given 24 hours prior to surgery. And the IV dye goes throughout the entire body. But when it gets to a site of cancer or any kind of neoplasia, the cancer cells, and specifically the cancer blood vessels, are very leaky. And so this specific contrast or dye leaks out into the nearby tissue surrounding the actual tumor. And it stays within that tissue for upwards of 72 to 48 or 48 to 72 hours and is still fluorescent. So if we give it 24 hours prior to surgery, the normal tissues of the body will just wash away that contrast. But because it leaks out within the area of the tumor, it stays enhancing. So then when I go forward with the thoracoscopic surgery, it really lights up where I need to consider surgery and surgical removal of these nodules. So just looking at these 2 sets of images here. So the row on the top is of, again, a patient who's actually a 7-year-old dog that had a breast cancer, meaning mammary carcinoma. She developed 3 different sites of metastasis. All of those 3 sites of metastasis were very small, meaning ranging from about 3 millimeters to 6 millimeters in size. If I were to not have the near-infrared fluorescence, it would be very difficult to identify and ensure that I'm safely resecting that nodule and not some other change within the lungs. And so, again, you can see the image A is of axial slice of her CT scan with the nodule of interest circled. Similarly, the image B is of using white light. So again, during that video, just with normal thoracoscopy, that's what the nodule looked like. Very hard to differentiate and identify. C, you can see if I'm just turning on the near-infrared fluorescence. So C is demonstrating that nodule being fluorescent with just the near-infrared spectrum of light going through. And then D, you can see, is actually a combination of white light with the near-infrared overlay. And so we use a Karl Storr's near-infrared Rubina system for this that allows us to really identify those nodules. And then similarly, the bottom row is actually the same patient. So E, you can see that's her nodule that's a little bit bigger, is about a full centimeter in size. F, you can see the deflated lung in which we did one lung ventilation, and you can see that nodule circled. And then again, G is that same nodule from F that is fluorescent, as you can see. And then H is actually a new nodule that was not identified on the CT scan, meaning if you look at the nodule in H, that was a fluorescent nodule that we identified during surgery that we actually did not identify in the CT scan. And so went forward with resection of that as well. And interestingly, it was another metastatic nodule. And so the near infrared not only allows me to identify the smaller nodules that are present within the lungs, but it actually may have a better opportunity for us to identify metastatic or pathologic lesions that could be missed on the preoperative CT scan. So again, really valuable tool for us as we go forward with these minimally invasive metastasectomies. After surgery, so we are doing a prospective monitoring of these patients. So they get a very standardized post-operative care, meaning that a chest tube is placed so that we can pull any excess gas or fluid from these patients. They're getting recheck examinations, meaning we're doing both x-rays and CT scans routinely for these patients at both 3 and 6 months after surgery. And then one of the really exciting things about this prospective trial is that because of the thoughtfulness that was put into creating the trial, we're actually doing a lot of basic science evaluations of both the patients, the samples, and their blood that is hopefully going to really give us a better understanding of the disease in general. So some of these secondary evaluations that we're looking at, one of them is that we are doing blood work, meaning we're pulling blood on all of these patients before, after, and then at 3 and 6 months after surgery, with the goal of evaluating and potentially validating a blood-based biopsy for patients with osteosarcoma. This is with the Brown Crompton at the Dana-Farber Cancer Institute. They are simultaneously, again, doing this in people. So we're looking at some cell-free DNA as well as circulating tumor cell assays for these patients before and after therapy. We know that we can do these tests, meaning that we know we can get blood from patients with osteosarcoma and find both cell-free DNA and circulating tumor cells. The goal of our evaluation is actually to see if we can identify these changes on a smaller level, meaning if we can detect smaller, more subtle changes within their quantified numbers to see, number one, if we truly get them down to a level of no evidence of disease or kind of minimal residual disease, as well as to use this as ongoing staging to evaluate for things such as drug resistance and early metastasis. And so again, the great thing is that we are hopefully going to be able to provide this as a test for our dog patients, but it does give us a chance to really evaluate for the technique and the testing that hopefully, again, can be used translationally both for dogs and for people in the long run. Other secondary evaluations that we're doing is we're working with the Ryan Roberts lab, which I know has also been on osteobites a couple of times now. So we're looking at things like the tumor microenvironment, meaning one of the big underlying questions for osteosarcoma is why do so many patients develop lung metastasis? Meaning, what is it about this particular cancer that has such an affinity for the lungs? And what is it about the lungs that allows this to happen in the first place? And so one of the things that we're looking at is the inflammatory milieu, meaning what are the cells that are surrounding lung metastasis that allows the facilitation of the development of METs, meaning is one of the things that the Roberts lab is actively looking at is we see that the tumor cells create this environment that is almost like a non-healing wound that allows it to actually set up shop and build a metastasis within the lungs. And so if we can get a better understanding of that process, we actually have the potential to start to give drugs that could block that process from happening in the first place, meaning that we can potentially prevent further lung metastasis for patients that develop it or even prevent it in the first place. Other things that we're looking at include epigenomic signatures as well as proteomics of these nodules, meaning trying to see if there are substantial mutational drivers that we could later on be used as targets, and similarly comparing a primary versus a metastatic lesion. So evaluating what's called a duo, so looking at the primary tumor and comparing if there's changes within the kind of epigenomic signature between the original tumor as well as the final tumor to see what changed within that actual cancer cell that again drove it to be or develop metastasis. So far we've enrolled 28 patients. Again, our goal is to ultimately get roughly 36 within this first stage of our MIMIC clinical trial. We are already developing MIMIC 2 and 3, but our goal for the first stage is going to be the 36 patients. So far we've enrolled 28 to date. 22 have completed their metastasectomy, meaning that we've had 4 that we did a staging CT scan, but unfortunately they were excluded due to the disease burden, meaning too much lung volume would have to be resected. And so those were not able to undergo surgery. 2 were excluded because on thoracoscopic explorer, we actually found that they had pleural dissemination of their cancer. Neither of them were osteosarcoma patients. One was a melanoma and one of them was a head and neck carcinoma. So unfortunately, they had carcinomatosis and melanomatosis, and so unable to proceed with the metastasectomy for those patients. But again, 22 patients so far have undergone surgery. Of those that have undergone surgery, we've included a variety of different tumor types. So osteosarcoma is definitely the most common that we're doing this for, just because we really know that there's a survival advantage for those cases. So 50% of an osteo. Carcinomas have encompassed 25%. Again, these are largely head and neck carcinomas. So squamous cell carcinoma, we've had a couple of mammary carcinomas as well. Again, melanoma and a couple of other sarcomas as well. Moving forward, we're only doing this for osteosarcoma patients through the trial. I am performing thoracoscopic metastasectomies for other tumors, just not through the trial. But moving forward, we'll be focusing on osteosarcoma. And then the number of nodules that we've had to remove, most commonly it's going to be 1, meaning the ideal patient is those with fewer number of nodules. So we try to catch it as early as possible and treat it as early as possible. So the majority of it just had 1 nodule. But again, we've included patients with up to 10 nodules. Again, not excluding them if there's only 3 to 5 to truly assess if there is a cutoff in which the survival advantage is not present. Again, the surgery that's being performed, so far we've surgically removed 83 lesions from these 22 patients. Only a couple of them have required a total lung lobectomy. One big kind of important thing to mention for difference between dogs and humans is that obviously in humans, if you consider a total lobectomy, that means removing one entire side versus the other. In dogs actually have 7 different lung lobes. And so we can remove 1 lung lobe and they still have 6 lung lobes left. So again, not necessarily the same kind of terminology as seen in people. The remainder have been partial resections. We've used 1 lung ventilation in about 70% of patients, so about 30% of patients who've been able to remove their nodules without 1 lung ventilation. And one of the exciting things that we found is that through the near-infrared fluorescence, we've actually seen that the malignant nodules are very highly fluorescent, and benign nodules are actually only partially, if non-fluorescent. And so that's one kind of very exciting thing that we're hoping to get out soon, is that if you do a CT scan and find a, let's say, 4 millimeter nodule, if you go in and use near-infrared and it's non-fluorescent, that may not actually need to be surgically removed, depending on the fluorescent level. Again, already talked about this, but again, what we're seeing so far is that these malignant nodules, meaning the true metastatic nodules, have been very highly fluorescent. We've removed, I believe, probably about 10 to 12 non-malignant nodules from lungs in these patients. That includes adenomas and osteomas. And one of the great things is that fairly consistently so far, we've seen that those are not fluorescent. And so looking to get that information out there soon. What complications have we seen? So intraoperative complications, we've only had a couple of 2 or kind of more severe complications. We've had 3 cases in which we had to, or 2 cases that we had to convert from a thoracoscopic approach to an open thoracotomy or a thoracoscopic assisted procedure. And so 2 in which we couldn't do it totally thoracoscopically. And then 1 patient, when we were doing the 1 lung ventilation, unfortunately we had an inadvertent puncture of a bronchi with the easy blocker. That patient did develop a post-operative pneumothorax that we had to treat just with conservative therapy, but again, a grade 2 intraoperative complication. Post-operatively, we've again similarly had a couple of complications, so 4 in total out of the 22 patients. Unfortunately, we have had 1 death, meaning 1 patient developed a ventilation pulmonary complication, in which we were unable to recover the lung injury that was sustained from the procedure and from the one lung ventilation. Outside of that, 2 patients developed a very mild pneumothorax. One required a pleurovac, and the other was able to be treated just conservatively over a couple of days. And then 1 patient that developed a superficial surgical site infection that was just treated with antibiotics. One of the really exciting things that we're seeing with these cases is that again, we have 96% survival to discharge, which is actually similar, if not better, than what we see for open or conventional thoracotomies in patients. The vast majority of them are being discharged within 24 hours after surgery. And I think that's one of the greatest things and biggest things that we want to emphasize for our clients that are considering this is that dogs are so comfortable that within 12 to 18 hours after surgery, we're comfortable sending them home. Again, we've had a couple that were not discharged within 24 hours. Those patients, it's typically not been because of pain. It is because of the ongoing pneumothorax, or if there are a couple of patients that develop other anesthesia-related complications such as GI ileus. Again, 1 patient we did have that unfortunately passed away prior to discharge. That was a post-operative pulmonary complication, meaning a very severe lung injury from the one lung ventilation. However, just as an example of kind of how well these patients can do, this is one of kind of our poster child patients for the MIMIC trial. So the video is one of my patients, Whiskey. It was she was just a little over 1 year of age at the time of surgery. She came to us from Texas. We went forward with 5 partial lobectomies in her for metastatic nodules. And you can see her here. This is less than a week after surgery, where she is out in the backyard, just loving life, playing ball like she wanted to do. This is actually the same patient that developed the surgical site infection, just because we really could not keep her quiet after surgery. So not too surprising that she developed an infection, but again, just treated with antibiotics and she did well. One of the other kind of exciting, interesting things that we've seen from our patients and how they're doing is actually the histopathology. And one of the surprising or unsurprising things that we've noticed is that there's a very common mismatch between the original tumor and these metastatic nodules. So for histopathology, again, of the cases that have had osteosarcoma, all of them have had at least one of their lung nodules come back as osteosarcoma, but a lot of them has also come back with non-metastatic pulmonary nodules. We've had a handful of cases that came to us with a specific history of a tumor type. We went forward with the pulmonary metastasectomy and actually came back as a primary lung tumor. Again, we're not doing pre-surgical testing to see exactly what this is at the time of surgery. And interestingly, a lot of these patients that historically may have been condemned to have metastatic lung nodules actually have a new tumor, meaning a pulmonary carcinoma, and which surgery could be curative for those patients. So one of the important things and things that we want to emphasize within the veterinary community is that you really can't assume that a new pulmonary nodule in a dog with a history of cancer is going to be metastasis, because we're not necessarily seeing that. The tumor mismatch in our cases so far, 40% of the cases that we've treated have had at least one nodule that was non-metastatic. And again, this is either a large pulmonary osteoma that you can't differentiate whether it's metastatic or non-metastatic, or the patients had a melanoma, came to us with a presumed metastatic nodule, and it came back as either an adenoma or a pulmonary carcinoma, so a primary lung tumor. So again, something that we're excited to be able to show, especially in vet med, that we really can't condemn a dog without knowing more about what the underlying diagnosis is. Follow-up, so the cases that we've seen so far that have gone through and are at least 6 months out, we've had almost 80% of them have completed the exit scan, meaning of these cases that we've treated so far, at least 80% of them have made it to that 6-month time mark. 30% of them have developed progressive disease by 6 months. So a third of dogs, unfortunately, have developed additional lung nodules within that 6-month time period. And then if we look at overall survivals, we have a roughly 252-day median survival, which is very similar to what we've seen before for metastasectomy in dogs. The range is, again, 2 to 710 days. So we had one patient that lived almost 3 years after this kind of surgery. And just for reference, for people that are unfamiliar with veterinary medicine, most of our dogs that are getting diagnosed with this are diagnosed at an age of like 8 to 12 years of age. And so a 3-year survival for a 10-year-old dog is a very good survival. Obviously, it's a little bit different when it's considered in people, but a 3-year survival for us is a very, very good outcome. Looking at the osteosarcoma specific survival, so those patients have been doing very well. So a 262-day median survival, which again is very similar to what we know from previously published data. And actually, the dog that is on the left, again, that is Whiskey, again, really a poster child for our clinical trial. She came to us a little bit over 1 year of age, diagnosed with the pulmonary nodules. She was given a prognosis of 1 to 2 months survival after the diagnosis of pulmonary nodules. She did have 5 nodules that we removed. She actually survived for roughly, I believe it was 9 months after surgery. Compared to 1 to 2 months, that 9-month survival was really important for those owners and for this patient. She actually made it to her 2nd birthday because of the clinical trial and going forward with surgery. And so was a really heartwarming patient to be able to treat and kind of exactly why we're doing what we're doing. So MIMIC clinical trial, again, our goal is to improve outcomes for dogs with stage 3 osteosarcoma, and honestly, not only dogs, but people, as we start to get a better understanding of the biology behind osteosarcoma. The goal is to deliver a metastasectomy as a routine procedure. So really exciting that we are expanding to other clinics across the US and Canada. Not only are we evaluating for this specific surgery and validating its use, but we are accelerating the study of osteosarcoma metastasis. And then some questions that we have for moving forward is what can we do to better treat our patients and get a better understanding of what's the best treatment for our patients? And so some of the things that we're discussing and are hoping to bring on in the near future include on-therapy metastasectomy, meaning if we know a dog has 4 pulmonary nodules, and we have a drug that we really suspect is going to be effective for osteosarcoma metastasis, can we go forward with removing 2 of those nodules, start the treatment, start the therapy, and then remove the second 2 nodules at a later date to see if that drug is actually having an effect on that patient's individual cancer. So we call an on-therapy or window trial where we can truly evaluate live in real time for that patient if the therapy that they're getting is going to be effective. And again, using this as a somewhat personalized or genomic-based adjuvant where we can remove some nodules, figure out what the mutational drivers are, put a patient on therapy, and then really assess for the drug delivery and drug effectiveness for these patients. And a lot of this comes down to trying to improve our ability to do a phase 2 clinical trial in dogs. Historically, or kind of dogma in veterinary medicine and in human oncology is that if you want to evaluate for a drug's effectiveness, typically what you need to do is you need to do primary local control and then do a blinded, randomized, very large population study of that drug in these patients and assess how they do overall over a long period of time. Often that's going to be a greater than 5-year study in dogs, and people that's going to be a greater than 10 to 20-year study in order to truly affect for the effect of that drug and the activity of that drug. We've done it in veterinary medicine. I think this trial is a very good example of this, where this specific clinical trial looking at rapamycin for dogs with osteosarcoma is one of the best developed and highest quality study that you can do both in vet med and outside of vet med. And unfortunately, they found that in this specific drug protocol, the rapamycin was not effective. Unfortunately, this study took over 5 years and a lot of money to try and get over 322 dogs into the therapy to see if this was effective. And over that 5 years, we found that it unfortunately did not have the effect that we expected based off of study data. And the challenge is that despite doing this study, we still think that rapamycin has a place for osteosarcoma treatment, but the actual drug protocol was not necessarily what was best within this study. And so the challenge is that A, it's costly, B, it's slow, and it's not very agile, meaning that if you want to test out several changes to the drug delivery, the drug schedule, it's really hard to do in this kind of historic or currently standard phase 2 trial, whereas we're really hoping to change the dogma around that, where we can use a different model, which is dogs with metastasis. We can go forward with surgically removing their metastasis, meaning giving them a proven survival advantage for their current state, test those actual nodules against the drug, test it against, again, some mutational changes, and then put them on an adjuvant therapy to then go assess and see if that drug is effective or is not effective in a state of minimal residual disease. And we can likely do this at a much more accelerated rate through this clinical trial, exactly like Mimic. And so really, really excited about the ability to use this and what it can mean for testing out drugs and treatments, not only for dogs, but for humans that are diagnosed with osteosarcoma as well. So this is all part of our what we are calling a bone cancer clinic here at my practice in North County, meaning that we are really doing a major emphasis on treatment of osteosarcoma at our clinic between myself, Ethos Discovery, and Dr. Mary Miller, our medical oncologist here. So we have a variety of clinical trials going on right now for dogs with osteosarcoma, so specifically looking at the Mimic trial, so thoracoscopic metastasectomy. We are doing a biologic study of local tumors, meaning that we're doing an amputation and then looking at the proteomics and surfaceomics of the tumors to, again, see if there are targets on the surface, meaning the proteins that are expressed that we could then go forward with treating. We're starting a new minimally invasive limb sparing surgery, meaning for patients that have local tumor, instead of an amputation, can we consider a cryoablation cementoplasty as a very non-invasive treatment for that local tumor to allow them to actually preserve their leg as they go through treatment, and then also looking at dysbiosis. One of the kind of weird but exciting things that we've seen is that dogs with metastatic osteosarcoma actually have a different GI flora than those that have a non-metastatic disease. And so really looking into the relationship of the kind of gut axis and see if that does have a role in just cancer biology or how these patients are responding to treatment. So that's it for me. I'll pause there and make sure I can answer any questions.
Thanks so much, Dr. Thompson. That was such a great overview. And it was, first of all, just fascinating to kind of learn about what this looks like in dogs, but also, as you mentioned, it's just a very well thought out trial where you're really kind of maximizing everything from this trial and all the other places where you're collaborating with and kind of taking advantage of the tissue that you're getting from the study. So
thanks.
Fantastic. I think we have a couple questions that came in, Max, if you want to tackle those.
Yeah, so the first one says that the scope was a helpful visual for peripheral/parental surface nodules. What was your metastasectomy? Sorry if I pronounced it wrong.
A tough one.
Options for nodules that are more embedded within the lung parenchyma?
Yeah, great. So really good question. So I guess the summary of the question is if I showed kind of the easy nodule to remove, meaning for these patients, a lot of pulmonary nodules are very peripheral and on the surface of the lungs. There are nodules that we will see that are more within the parenchyma and more towards the hilus, or kind of where the bronchi and the vasculature arises. For those cases, we definitely do have to consider more of a total lobectomy. And veterinary medicine, or kind of for my cases, that typically means using a stapled lobectomy, meaning going forward with removing either a very deep wedge or potentially the entire lung lobe, depending on the location of the nodule. And that's where it does get a little bit frustrating, where every patient and every nodule is so different, and kind of why we designed this to only exclude patients in which 60% of the lung volume had to be resected, because there are some big 4 or 5 centimeter pulmonary nodules that are on the tip of the lung, that surgery is like a very quick, easy ability to get in and remove that. Whereas there are also some like less than 1 centimeter nodules, but if it's at the base of the lung at the hilus, that could be enough to preclude a patient from going forward with surgery. So very good question. If we have the ability, I always do a tiny little partial lobectomy on the periphery, but there are times that we have to do a complete lobectomy at more the base of the lung, depending on the location.
Oh, Christina, you're muted if you're talking.
Oh, yeah. Do you want to grab that next question too?
Oh, yeah. So the next question in the chat is, if this were to move from research to standard veterinary care, how much would it cost a family who's chose this treatment for their pet?
Yeah, great question. So cost of care is it is one of our biggest challenges in vet med. This is obviously drastically different from our human oncology counterparts, where unfortunately there's insurance to cover a lot of the care. For us, we have to do things basically as affordably as possible to make sure that we are not limiting care to, again, just those that have the disposable cash. The easiest answer to your question is that this is very expensive, meaning that typically a thoracoscopic lung surgery in a dog is going to run anywhere from like $8,000 to $12,000, and so that is very expensive for any kind of owner to consider. The great thing is the clinical trial does provide a financial incentive for those that are participating for this within research. But yeah, if we are to do this for a patient outside of the trial, it is expensive. Again, typically right around that $10,000 range for us in our hospital currently. That does change often. And one of the frustrating things is that we are very much at the mercy of the cost of human healthcare devices. So just for reference, like one of the staplers that I use, the stapler alone can cost upwards of like $600 to $800. And so we have to try and do surgery where we're not losing money, but still able to kind of provide this care. And it does get very costly.
And thanks, Dr. Roberts, who was just made a comment that he's very excited about the on-therapy window studies, as they will help us learn more about what our proposed therapies are actually doing. Very valuable research. Thanks, Dr. Roberts. And along those lines, I actually have a few questions just about the surgery itself. So towards that end of being able to do these kind of on-therapy window studies, are you able to do these like repeated thoracoscopies, and how many could you do? And
Yeah, good question. So you can do repeated thoracoscopic metastasectomy, meaning that in this study, I've only had one patient so far that we've done a repeated secondary metastasectomy for them. Again, you can theoretically remove up to like 60-70% of the lung volume in a patient, and they can still go on to do very well. The ability to repeat this, again, really depends on the location and the size of those nodules as to whether or not we'll have the safety to do that. But there are definitely select cases where we will do a metastasectomy. We can put them on drug, we can put them on trial. If they develop another metastasis, we can go forward with surgery for that. And they do so well, meaning that, again, within about 12 to 18 hours, these dogs are really acting like nothing even happened. And so we have a great ability to provide this for them without really affecting their quality of life.
Yeah, do dogs get chest tubes after their pulmonary surgery like humans do?
Yeah, exactly. So the part of our kind of standardized post-operative care is at the time of surgery, we'll place a chest tube, and the chest tubes are in place until we get negative, meaning no fluid, no air. Both in dogs and people, having a chest tube in place, you'll always get some degree of fluid because the tube itself is somewhat inflammatory. So for our study, we are pulling, or one of the criteria as to when they can be discharged from the hospital is that we have to have negative from air for their chest tube. And so in kind of our protocol or my practice, we will put the chest tube in, and then we will aspirate or kind of suction the chest tube every hour for the first 4 hours. And if we see that we don't get air within that first 4 hours, we'll pull it. Some of those patients still need to have a chest tube in overnight, just if there's any residuals. But typically, again, by that 18 hours, we're able to pull it and they're able to go home.
And so for most of the ones that you've done, are they like, if you have a dog who has nodules like bilateral, how do you approach that? Because I'm assuming you got to do one at a time.
Yeah, and I actually do a full thoracoscopic explore of the entire lung fields prior to going forward with the metastasectomy. Again, a lot of difference in anatomy from dogs to people, but I typically will have them positioned so that they're on their back, and we actually shave the entire chest area just so that we get access to everywhere. I'll start with the subxiphoid port, meaning I'll put the camera in through just under the xiphoid to take a look at both the right and the left hemithorax. And then typically for the actual surgery and positioning, let's say if I'm doing surgery on a nodule on the right side, we'll then move them into left lateral recumbency so that the right side is kind of within the area of our working zone or working space. And that's where the one lung ventilation really comes into play, where we will block off that right side, just breathe through the left side, and then I have kind of a good amount of space on the right side to be able to identify and resect those nodules.
And do you have to, but let's say a dog has bilateral disease, do you do one side and then they recover and you do the both?
We do it all at once. And I would say I should have kind of pulled that data, but in our cases, if a patient has more than one, I would say almost all of them have bilateral disease. And so it's actually quite common for me to have to surgically treat the right side. We will deflate the one lung ventilation, make sure we're breathing well on both sides, and then go forward with deflate the left side so that we can do surgery on that side.
Got it. And of the dogs that you've currently that have enrolled in the trial, or just even generally, I'm just curious, like for osteo, how many dogs kind of present with lung mets at diagnosis when they are already, you're dealing with a primary tumor? Or are these mets that you're seeing after the primary tumor has already been treated, they've been amputated?
Yeah, it's actually quite uncommon to have simultaneous primary tumor and lung metastasis, meaning that in our case, like just general practice here, it's probably about 10% that we will see that by the time of diagnosis of the primary tumor, we have lung metastasis. So not very common, again, just 1 out of 10 dogs. The majority, I think all but one dog in our current clinical trial developed late stage metastasis. So only one was diagnosed with a metastasis at the time of diagnosis. And actually, interestingly, that patient did not have a metastatic nodule, meaning that as a dog that had a primary osteosarcoma of I can't remember, it's a forelimb or a back limb, but had a lung nodule. We did a metastasectomy and it came back as a primary lung tumor and a low-grade primary lung tumor. So likely cured from the lung disease and then now is undergoing treatment for adjuvant chemo for the osteosarcoma.
Great. And so, so first of all, congrats, because you've actually enrolled many patients considering the number of sites that you have. And so I think you only had, 6 more patients to go. And so once you're done with the trial, I mean, you mentioned like ideally kind of standard clinical practice. Is that something, I mean, do most hospitals have the type of equipment that you have to be able to do this and the expertise? Is it, I don't know, is there like an NCCN for dogs? Like how does this get?
Yeah, so there's an NCCN. The challenge is honestly, the technology is a big prohibitor right now. So there are a lot of veterinary specialty hospitals that can do thoracoscopic surgery, meaning in every major metro area, there's probably a surgeon that will do laparoscopic or thoracoscopic surgery. There's a very good number of surgeons across the country that will do thoracoscopic lung lobectomies. The biggest challenge is that the near-infrared technology is not seen or is not everywhere. And so the challenge that we've had in expanding this is that we need a practice that is comfortable doing thoracoscopy, has done thoracoscopic lung lobectomies, and then also has the ability to do near infrared. We're really trying to push that, meaning that we're actually working on a training course for near infrared thoracoscopic surgery right now. We're working on kind of getting the technology in more people's hands so that this can become more common. But that seems to right now be the biggest limiter.
You know, I was going to say, I was actually going to ask for the fluorescence guided. Is that something that's new in this trial, or is that something that has been kind of standard practice? I mean, I know not everyone has a technology, but it's not. Is this the first time it's being used in this trial for this?
Yeah, I mean, yes and no. So there's a
human trial going on too for that.
Yeah. So it's been in, so near-infrared fluorescence, just as a medical dye and a medical technology, has been like in use for decades, meaning like 60, 70 decades, mostly for retinal disease. It only recently, and probably last 15 to 20 years, has now been a bigger player within minimally invasive surgery. And initially, all technology kind of goes through these phases where you are starting to use it. Everyone's excited. You use near-infrared for literally everything. And now we're kind of getting to this better phase where we're refining its use and have good reason to use it, such as the metastasectomies. And so I would say over the last probably 3 to 5 years, it's really ramped up in its commonality. There are studies in veterinary medicine and human medicine on the use of near-infrared for lung tumors, for sarcomas, for a variety of different kind of surgical oncology procedures. There's nothing in the veterinary medicine field that's published on near-infrared for metastasectomies yet. There's, I would say, 2 or 3 that have looked at lung tumors and lung lobectomies, but this will be the first, as long as we get out soon enough, on actual metastasectomies.
Very cool. Well, thank you so much, Dr. Thompson, for joining us on OsteoBytes today and for making it better for our 4-legged osteosarcoma patients. More information on this and all OsteoBytes can be found on our website at mibagents.org, on our MIB Agents YouTube channel, and at your favorite podcast place. We hope to see you next week. We are going to be joined by Dr. Alice Zaragni from UCLA, and she will be discussing a human clinical trial called PREMOST, an organoid-based functional precision medicine trial in osteosarcoma. And the goal of the trial is to study the feasibility of using organoids for predicting drug response and guiding therapy in osteosarcoma. You can find our OsteoBytes lineup for the next few months on our website. And if you ever have any ideas for topics that you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again, Dr. Thompson and Max, for spending an hour with us today. And thanks to all of you for taking time out of your busy days to join us. We hope to see you back here next week on the 13th. We're going to be chatting with Dr. Alice Zaragni. Thanks so much. Thanks, Dr. Thompson. Thanks, Max. Thanks, everyone.
Thank you so much. It's a privilege. Thank you.